As you know, there's a big problem of the obesity that increasing every day, and even in developing country as Thailand, we also have the incidence of morbid obesity about 6.9% last 10 years. Nowadays, increasing to 13. And as our last speaker mentioned before that there's a evidence that bariatric surgery can be improved the. Thank you. Can be improved the weight loss and also can improve the diabetic control. So nowadays, because gaining of the sleep gastrectomy can popular, and sleep gastrectomy may provide a comparable result to the bypass with less complication. However, there's a meta-analysis report on 2015 that tried to compare the result of the gastric bypass and sleep. That show very similar result in diabetic control. But you can see only 2 randomized control trials at that day that try to compare the result, which is belong to Dr. Vijay and Phil Shower from Cleveland Clinic. So in our center, we start to perform the bariatric surgery 10 years ago. Nowadays, we perform about 200 cases a year. Last year, we have 50% bypass and 48% of sleeve and 2% of redo surgery. We have complication about 1.7%. So my question is, which the procedure is best for control diabetes in morbid obesity patient, and how long the effect lasts. So we decided to run the randomized control trial to compare sleep gastric and bypass with a 2 years follow-up. My primary endpoint is glycemic control at 2 years, which focus on hemoglobin A1C and the remission rate. The definition as mentioned before from the last speaker, and secondary endpoint is a percentage of the excess weight loss. The study design is prospective, randomized control trials with single blind trial. The randomized was done by block of flow, and the envelope has been opened by the surgeon at the time of the procedure start, and patient will not know what kind of procedure they have. The sample size was calculated, which should be 42 in each arm. And interim analysis and stopping policy has been described at the slide. My inclusion criteria is a patient with BMI age between 15 to 60, and BMI between 32.5 to 60. The history of diabetes should be less than 10 years and have the history of poor control diabetes with plasma hemoglobin A1C less than more than 7 at the 1 week before the operation. They should have ability to follow up and physical performance safe to do the operation. For the exclusion criteria is previous bariatric surgery and lack of the informed consent, and also history of additional on alternative medication for control weight and diabetes. Drop-off criteria is cannot follow up within 30 days, and death which is not related to the operation or the diabetic complication, and also the condition that they cannot receive anti-glycemic control according to the ADA guideline, such as pregnancy or adverse side effect for the medication. So our procedure performed by the same surgical team, which is the 30 cc of the gastric pouch and 150 for the root limb, and gastrogynecostomy performed by the circular stapler number 25. For the sleep gastrectomy, as performed by 4 centimeter enteral spelling, and sizing used we're using the Bookie dilator 36 frames. As I mentioned, we have the same protocol, post-op protocol for the patient, and if they have the rising of the hemoglobin A1C, we have protocol of giving the anti-glycemic control according to the ADA guideline. We follow up every 3 months. And statistic protocol, as I described in the slides. So we include the patient about patient 104. Okay. And 48 perform the sleep gastrectomy and 56 perform the bypass. As you can see that the no statistic significant difference in the demographic data of the patient. The mean BMI is about 46 in bypass and sleep 47. The mean hemoglobin A1C is 8.9 for the bypass and 9 for the sleep. No major complication, only 2 wound infection in the bypass. And as you can see, had significant improvement of the hemoglobin A1C at 6 months and 2 years after the operation compared to its baseline hemoglobin A1C. And the diabetic improvement rate is 100%. For the comparable for 2 procedures, mean hemoglobin A1C is almost the same between 2 procedures. And for the remission rate, is show no significant difference between 2 procedures. Even the bypass has a better number. Okay. And the level change of hemoglobin A1C is almost the same. For the weight loss, we see that bypass have better weight loss. For the conclusion, for our result, we can see that for weight reduction, we have bypass show significant better result for the compared to the sleep. However, for the glycemic control, the result is comparable. Our study has limitation because we are not the large volume center, so we try to conduct the more study with better design and more sample size and longer longer follow up to try to find the evidence that reveal why bariatric surgery can heal the diabetes. Thank you.